start our fifth and last session of metabolic disorders, of rare metabolic disorders. Our first speaker today is Dr. Adnan Al-Sheikh. Dr. Adnan is an associate professor of pediatric and consultant pediatric endocrinologist at King Abdulaziz Medical City, Jeddah, and King Saud bin Abdulaziz for Health Science University and Associate Dean, College of Science and Health Profession at King Abdulaziz University in Jeddah, Saudi Arabia. Has a lot of publications and shared a lot of international and national symposium as a speaker. Dr. Adnan is going to talk about monogenic diabetes mellitus. تفضل دكتور عدنان.
السلام عليكم ورحمة الله. Thank you, Dr. Fawzia, for the introduction, and thank you for the invitation. So I will talk today about monogenic diabetes. This is an outline of my talk. I'll start with challenging cases, and then the forms of monogenic diabetes and physiology of insulin secretion, and then clinical aspects of monogenic diabetes, and then the diagnosis and treatment. So let's start with the background of monogenic diabetes. So as you know, diabetes classification by the American Diabetes Association is either type 1 diabetes, which is the main diabetes in children. It's caused mainly by insulin deficiency, and then type 2 diabetes, which is mainly has a background of insulin resistance, and then gestational diabetes, and the third, or actually the fourth, is the rare types, which include monogenic diabetes and others. So this is this is the starting of my talk. So monogenic diabetes in general, it's a polygenic disease. But there is rare types of diabetes, which is monogenic. So when we say monogenic, we mean that there is a mutation of one gene causing diabetes. But for polygenic, there is multiple genes, mutation or defects causing diabetes. So what are the forms of monogenic diabetes? The first one and the main one is the MODY or maturity onset diabetes of young, and then neonatal diabetes, and then diabetes associated with syndromes, and then monogenic autoimmune diabetes, which is inherited autoimmune polyendocrineopathy, and the last is mitochondrial diabetes. So with that, so the other maybe easier classification, is it beta cell dysfunction causing a defect in insulin secretion, or it is an insulin receptor defect? So beta cell dysfunction or defect in insulin secretion is caused mainly by MODY or neonatal diabetes or inherited autoimmune polyendocrineopathy, or mitochondrial diabetes, or syndromic diabetes like Wolcott-Rallison syndrome, Wolfram syndrome, or Rogers syndrome, or Fanconi-Bickel, and others. Or it could be insulin receptor defect like Robson-Mendel syndrome, or Lebracanism, which is Donoho syndrome, and Bardet-Biedl syndrome or Alstrom. And these are really a rare condition. From each, we have maybe 2 or 3 cases in our center. So just to highlight the classification of monogenic diabetes, it's either beta cell dysfunction like MODY, neonatal diabetes, or syndromic diabetes, or it could be insulin receptor defects like Robson-Mendel, or Lebracanism, or Bardet-Biedl or Alstrom, or monogenic autoimmune diabetes like ABS syndrome or IBEX syndrome, which is the immunodysregulation polyendocrineopathy, on the X chromosome or IBEX-like syndromes. So let's start with the physiology of insulin secretion. Uh, Glucose is the main stimulator of insulin secretion. So with the carrier, glucose is carried by the glucose transporter 2 inside the islet cells. This is the islet cells. And then it is metabolized by the glucokinase and go in the mitochondria to have the glucose phosphorylation, and that will cause high ATP ADP ratio. That will close the potassium ATP channel. So when it is closed, there is a depolarization of the membrane, followed by influx of potassium outside the cell and calcium inside the cell, and that will cause insulin granules, secretions from the insulin granules. This will need actually the nuclear transcription factors, which is also shown here inside the nucleus. It's a lot of cascade depend on each other. So if there is defect in one, it will affect the other. Like BDX, if there is a BDX1 gene mutation, transcription factor mutation, that will cause pancreatic aplasia or agenesis. So let me start with the challenging cases. So case number 1, this is an 80-year-old boy presented with nocturnal enuresis. Of course, we thought of diabetes, and we found that the postprandial sugar was 176, which is fine, but the fasting blood sugar was high. We know that any blood sugar above 100 or above 110 is abnormal, and above 126 is diagnostic of diabetes. There was no glucosuria. The hemoglobin A1C was high. Any hemoglobin A1C above 6 is diagnostic of diabetes. So we checked his insulin autoantibodies like islet cell antibodies and GAD antibodies, and it was negative. So at that time, we said, yes, he's diabetic, but we don't know which type. So we were thinking, which type of this of diabetes this child having? Is it moody? Is it type 1 diabetes? Is it type 2 diabetes? Is it other rare forms of diabetes? Or is it drug-induced diabetes? So with these findings, we said, let's do genetic testing, and it came as glucokinase gene mutation. So this is MODY1. So the diagnosis of this patient is MODY1 diabetes or maturity 1 cell diabetes. So just to remind you, where is the glucokinase? So glucose is uptake by glucose transporter inside the islet cell, and then the first step in islet cell in glucose metabolism is the glucokinase. And so if there is a defect in this enzyme or the gene producing this enzyme, then the patient will develop MODY type 2 diabetes. So what is MODY2? It's a glucokinase mutation. It is actually the commonest cause of MODY in children, and it causes incidental fasting hyperglycemia like this patient. In UK, it accounts for about 20 to 30% of MODYs in the UK, but in Saudi Arabia, we don't have data. And usually it causes a higher threshold of glucose stimulation. It has a variable presentation from mild hyperglycemia to actually in adults, usually it presents with gestational diabetes, or it will present with non-progressive hyperglycemia. So they will have their hyperglycemia not worsening, and usually it just need a diet treatment, doesn't need any insulin. This is actually one of the patient in National Guard Hospital in Riyadh, a patient of Dr. Angham Al-Mutair, who published this case, just treated a moody patient, just treated with diet, and you can see that the hemoglobin A1C is maintained. So it is really non-progressive disease controlled diabetes. Diabetes is controlled well with diet only, without any other treatment. So let's move to case number 2. Wissam is one of my patients. He is 6-year-old Saudi boy presented with polyuria and polydipsia, and the blood sugar was high, 215. There was no other family history or no other systemic condition, but there is a strong family history of type 2 diabetes. On examination, he was completely normal and remarkable examination, and he is not obese and no acanthosis nigricans. So based on these findings, on his age and the symptoms and the blood sugar high, we thought that this is actually type 1 diabetes, and we started him on insulin. But we found that blood sugar normalized quickly, and then he went into hypoglycemias, even with the small doses of insulin. So this is his pedigree. There is strong family history of type 2 diabetes. And based on this, we said he is not behaving like type 1 diabetes. Let's do the antibodies. So we did the antibodies, islet cell antibodies and GAD antibodies. And to our surprise, it was negative. Remind you, he's an 8 years. So we did also fasting insulin and C-peptide before actually any treatment, and it was completely normal. His insulin was 18. So with that in mind, he got a strong family history, negative antibodies, and requiring really very low doses of insulin. We thought that this is maybe a MODY case. So we did the genetic testing, and the results came after about 2 months, and it showed a mutation of the cell gene, CEL gene. And this actually consistent with the diagnosis of MODY 8. So the diagnosis of this patient, Wissam, is MODY 8. Now, after about 3 years, his brother Abdulaziz presented with also diabetes symptoms, and blood sugar was high. So we started him on insulin, and we did the genetic testing, and also it confirmed that he got CEL gene mutation. So also Abdulaziz and Wissam, the two brothers, has MODY 8 diabetes. The interesting for the Abdulaziz that after 1 year he was off insulin, and his diabetes is controlled on diet, and there is no hyperglycemia. So look at that, two brothers with the same mutation, with the same disease, exactly same mutation of cell gene, and they got a different presentation. So very interesting. So what is MODY 8? It's caused by cell gene mutation, and usually they have an pancreatic exocrine insufficiency followed by diabetes. But our patients, we investigated them, none of them, both of them, they have no exocrine diabetes. So so let's just give you a high background about MODY. So these are heterogeneous group of monogenic diabetes. It is inherited as autosomal dominant condition, and once it is usually before 25 years of age, and it causes non-ketotic diabetes, and they don't develop DKA, and the presentation is very variable from asymptomatic to mild to severe, but usually they are mild asymptomatic, and usually they are not non-obese children. They present, as we mentioned, with gestational diabetes, and really there is variability according to the type and severity. So MODY account for about 2 to 5% of all diabetes. That is in the Western countries. We don't have really data in our country. And the most characteristic finding, this is a diabetic child or young adolescent who have negative autoantibodies, islet cell antibodies. There is, until currently, there is a known 13 different gene mutation causing MODY. The commonest is MODY 3 and MODY 2, causing about 80% of the condition, and MODY 1 is actually the third commonest. Just to remind you, so this is the islet cell, the glucose uptake by the glucose transporter, and then the first step is glucokinase. This is our patient to case 1. And then with the glycolysis, there is an increased ATP channel, and you can see that with the increased ratio, the potassium ATP channel close. That will cause depolarization of the membrane with influx of the potassium outside and the influx of calcium inside, and release of insulin granules from the islet cell to the circulation. Now, if there is a mutation of the glucokinase, it will cause MODY2. And if there is a mutation of any of these nuclear transcription factor, it will cause MODY1 until MODY10. So glucokinase mutation, these are the genetic causes, will cause type 2. And MODY3 is cause about 50% of the main causes of MODY. And then there is MODY1, MODY5, and MODY4, and MODY6. And our patient who had MODY8, the cell gene mutation, and of course others. So the first case was glucokinase mutation. The second, two brothers has MODY8 with the cell gene mutation. And the fourth cases I'm going to present is an insulin gene mutation. This is MODY8. The commonest is actually MODY3, which caused by mutation of the hepatocyte nuclear factor 1 alpha gene, followed by MODY1. And the third is MODY5, which is a severe disease. So MODY3 is actually the commonest cause of or type of MODY. This is actually a severe disease. They will present with not asymptomatic hyperglycemia, but they will all need insulin. And the interesting finding in MODY3 that they are very sensitive to sulfonylurea, and they will respond to oral hypoglycemia, and we will be able to stop insulin treatment. And then MODY3, they got actually very interesting finding. They have a low renal threshold or glucose. So if you diagnose one case, then you can screen the family by checking the glucose urea. If it is positive, then go ahead and do the genetic testing, because it's the marker for the unaffected carriers. MODY1 is the second commonest, and they will present with also hyperglycemia, and they respond well to sulfonylurea. Initially, they can develop macrosomia and neonatal hyperinsulinic hypoglycemia, and they got in the main causes inactivating mutation of the hepatocyte nuclear factor 4 alpha gene. And then MODY5 is really uncommon in our country, an uncommon disease. Lucky because it's really a severe disease, caused multi-system involvement affecting the kidney, the pancreas, the GI, and usually it end up with mortality before maybe 15 years of age. So it affects really multi-system and mainly renal disorder. So this graph will show you that glucokinase, they will be non-progressive disease. MODY3 and MODY1 will cause really mild, more moderate disease, while MODY5 will cause severe disease. So the characteristics of MODY in general, that they will present with fasting hyperglycemia, maybe just isolated glucose urea, and they have negative autoantibodies. Sometimes they have extra pancreatic dysfunction, and sometimes they present with just gestational diabetes. They don't have the usual features of type 1 diabetes or type 2. This is really how we differentiate. And then it has a pedigree of autosomal dominant condition. We say that it's really underdiagnosed and misdiagnosed because a lot of ladies who present with gestational diabetes would not have the genetic testing. And we can easily differentiate from other types of diabetes by lacking the characteristics of type 1 and type 2 diabetes, and by specifically they are non-obese and they have negative autoantibodies. There is a study done in Norway in Norway, and they showed that for about 50% they were MODY 3 and 33 MODY 2. In Italy, about 6% of their diabetic children, they were confirmed to have MODY, and about 55% of them were MODY. Now in Middle East, there is really no studies. I found this study done by Tanir, and there is really no studies in the Middle East to confirm. So let me move to case number case number 4. This is a 7-year-old child presented with polyuria and polydipsia and weight loss. Blood sugar was actually normal, and there was no glucose urea. So this ruled out diabetes by this finding. But we found that we did electrolyte, and we found that the sodium is high, 155, and the urine was diluted. So the diagnosis is central DI. And at that time, we treated with desmopressin, and he responded very well. And after 3 years, he started to develop visual disturbance diagnosed by ophthalmologist as an optic atrophy. And after 11 years, he developed hyperglycemia. So the diagnosis, I'm sure it is clear to you. This is what? This is most likely Wolfram syndrome or Dedamut syndrome. So that will be my introduction to syndromic diabetes. So the first one is Wolfram syndrome. And the second, which is commoner in Saudi Arabia, is Wolcott-Rallison syndrome. I have one family, and our colleagues in King Abdulaziz University have one family. So we have at least we have maybe 10 to 15 cases we know in the diabetes centers. And then Rogers syndrome and mitochondrial diabetes. So Wolfram syndrome, the case which I present with autosomal recessive, they present with DI and followed by optic atrophy, and later they develop diabetes and also deafness. It is really rare, but because it is autosomal recessive, we see it in Saudi Arabia, and it's caused by the mutation of the Wolfram gene. The second syndromic case is Wolcott-Rallison syndrome. They have skeletal dysplasia, and then they develop diabetes, and also they got liver disease. They die because of hepatic failure. My patient died because of actually fulminant hepatic failure, part of the disease. The main mutation is called by EFAC, gene mutation, and it is not rare in Saudi Arabia. My fifth case is Malik. He's also one of my patients, presented at 1 month of age with polyuria and thirst sensation, like he's irritable, he's crying. The mother need to feed him every now and then, otherwise he doesn't settle. We interpret it as thirst, and he's not gaining weight, and blood sugar is so she brought him to the hospital, and blood sugar was very high, 240, with 3+ urine glucose. We checked the hemoglobin A1C, and it was high. A1C was 8. Digging in the history, the parents were cousins, and there is positive family history of 2 cousins with neonatal diabetes. So we did the autoantibodies, and it was negative. Of course, we started him on insulin, and we did the genetic testing, and it confirmed he found to have mutation of insulin gene. So he has insulin gene mutation causing actually neonatal diabetes, or they label as MODY 8. MODY 10. So this is an autosomal dominant disease. They have negative autoantibodies, and this is the insulin gene molecule. You can see that this is the alpha chain, and this is the beta chain, and this is the C-peptide, and there is mutation of the insulin gene itself. So they have no insulin gene production. With this introduction to neonatal diabetes, so they could have transient neonatal diabetes or permanent neonatal diabetes, or they could be syndromic. So transient, usually they will present in the first 6 months and it resolves. In general, neonatal diabetes, they will present in the 6th month of age, and they could present with DKA. It's a heterogeneous disorder. It's really rare condition. In our center, we have around maybe 10 patients. Total in GHA Jeddah and Riyadh, we have total maybe 25 patients. It could be transient or permanent. And I will talk about the permanent because they could be, remember I talked about PDX gene mutation, which is the main transcription factor. So if they have the PDX mutation, they have pancreatic hypoplasia or agenesis, or it could be syndromic, like the patients we presented, Walcott-Rallison, who present with neonatal period. Or it could be insulin gene mutation like Malik and his cousins, who have neonatal diabetes due to insulin gene mutation, or it could be ATP channel. And I will talk about the AT syndromes. It's actually the IBEX, one of the syndromes, the IBEX gene mutation. They have really severe polyendocrineopathy and autoimmune process, and enteropathy. They present with diarrhea, and those patients usually die in the first 5 months of age. Or it could be due to STAT3 mutation, where they have polyendocrine autoimmunity diabetes due to activating mutation of the STAT3. So let me talk about the ATP channel mutation, just to show you, just to remind you where is it. So the ATP channel consists of 2 proteins, the sulfonylurea protein, which is and the potassium or KER6 protein. Both are actually encoded by the ABCC8 gene, and the other one is encoded by the KCNG J11. So if there is a mutation of this gene, or this gene, the ABCC8 or KCNG, then it will cause neonatal diabetes, or they call it MODY12 or MODY13. So mutation of the potassium ATP channel, if it is activating mutation homozygous, then it will cause neonatal diabetes. If it is heterozygous, it will cause MODY12 or 13. If it is inactivating mutation, then this is very interestingly, it will cause hypoglycemia, or they will cause call nesidioblastosis or BHHI. So how to treat monogenic diabetes? It's different according to the type. MODY2 will need diet only. MODY5 will need insulin, while MODY3 and MODY1 will respond very well to sulfonylurea, and also neonatal diabetes secondary to ATP channel mutation will respond very well to sulfonylurea treatment. This is why it is important to do the genetic testing, because you could really change the treatment from insulin to sulfonylurea. This study showed that really they respond very well to sulfonylurea after about many months. So the SBAT guidelines showed that all patients, or recommend that all patients with diabetes diagnosed in the first 6 months, it is recommended to do the genetic testing. If it is less than 1 year, then do autoantibodies. If it is negative, then you have to do the genetic testing. So in conclusion of my talk, it's important to identify the monogenic forms of diabetes mellitus, because that will affect really your decision of management. Think of MODY patient if your patient presented with incidental hyperglycemia, like the first case I presented, or if the parents has a strong history of early onset non-insulin diabetes at around the age of 20 or 22 years of life, or if there is just impaired glucose intolerance, or there is gestational diabetes. A lot of type 1 diabetes, apparently, if they are actually autoantibodies negative, then they could be MODY. And if they don't have the characteristic of type 1, they could be MODY or other monogenic diabetes like neonatal diabetes. So test for genetic causes of neonatal diabetes in any patient present with diabetes less than 6 months of age. It is possible and available, but it is really expensive. It will cost around maybe 3,000 to 5,000 Saudi riyal. If mutation with the, but it is really worth it, because if mutation with the ATP channel, then you could stop the insulin and start sulfonylurea, because it could be MODY 12 or 13, which is the potassium ATP channel, or it could be MODY 1 or MODY 3. With that, I would like to thank you for your attention, and thanks a lot for your attention.
Thank you, Dr. Adnan. We will leave the questions until the end of our session. Our next speaker is Dr. Susan Hussein Daffa. She's a senior consultant neonatologist, currently head of pediatric in NICU in Aya Specialist Hospital, previously head of scientific committee for neonatal care in MOH in Jeddah region 2018. Published a book about international standards of neonatal in ICU 2018. Today she's going to have a case presentation about update on persistent pulmonary hypertension in neonates. تفضلي دكتورة سوسن.
السلام عليكم ورحمة الله وبركاته. First, I would like to thank Dr. Fawzi Al-Sharif for this nice introduction. And also, I would like to thank her for this invitation, and to thank Saudi Women Hospital. Actually, my talk is completely different from the other talks during all this webinar. It's not a metabolic disease, but it's rather than a neonatal disease. Today, I will talk about update and management of persistent pulmonary hypertension of the newborn, which is a really difficult disease to be managed by the neonatologist. First, I will present the case, and then I will talk about the different new modalities of management of persistent pulmonary hypertension. This case presented to us as a term baby who was a 31-week gestation, male, 3.5 kg, and he was delivered by emergency CS due to meconium strain glycol. Baby developed, respiratory distress at birth and needed mechanical ventilation. At the age of 18 hours, it was noticed that oxygen requirement increased to 100% and the PIP increased to 28. The PEEP increased also to 6 centimeters, which is a high ventilatory setting. Pre- and post-ductal oxygen saturation monitoring showed also a difference of more than 10%, which is a diagnostic for persistent pulmonary hypertension. And also there was fluctuation of oxygen saturation. Then a diagnosis of persistent pulmonary hypertension was made. Okay, management. How did we manage this patient? Of course, we started sedation with fentanyl infusion. We started inotrope to maintain blood pressure. We also controlled ventilation with high ventilator setting, and the baby continued to have desaturation. So what is the next step? This is the question. Would you use high frequency ventilation? Would you use nitrous oxide inhalation therapy or ECMO? Before I say what we did for this patient, I will go to the different modalities and the update of persistent pulmonary hypertension of the newborn.
Okay, so how we call persistent pulmonary hypertension of the newborn? How we define it? It was described previously as persistent fetal circulation, and earlier was considered a disease of plaque preterm and term units, but currently it occurs in preterm units. How we define it? Usually a normal baby, the pulmonary pressure will fall down and the lung circulation will improve. But for some reason, a disease in the lung, this will not happen and the pulmonary vascular resistance will increase and it will cause pulmonary hypertension. So it is disruption of normal perinatal to neonatal circulatory transition and sustained elevation of pulmonary vascular resistance. The incidence is 1 to 2 births per 1,000 live births, and the majority of infants will have other respiratory disease associated with pulmonary hypertension. The commonest is meconium aspiration syndrome. It accounts for 41%, pneumonia, respiratory distress syndrome, which accounts for 13%, congenital diaphragmatic hernia, which accounts for 10%, pulmonary hypoplasia, which accounts for 4%, and some of the cases, 17%, are idiopathic with unknown etiology. So how usually these cases present? They present usually within the first 24 hours of life with signs of respiratory distress and cyanosis. And most neonates will require extensive resuscitation at birth. They will have cyanosis, signs of respiratory distress, and on cardiac examination, you will have a prominent pericardial impulse with prominent second heart sound. Also, you will find a harsh systolic murmur of tricast insufficiency at the lower sternal border, and the baby color is, we call it ash color or dusky color. How you will diagnose it clinically? Okay, so first you will put the baby on pulse oximeter. You will find a difference on the right radial and the umbilical artery. There will be a difference of oxygen saturation 10%. However, absence of this difference does not exclude persistent pulmonary hypertension of the newborn. You will find the baby persistently hypoxic with labile saturation. Then we'll go to the blood gas. Usually PO2 will be less than 100, with even if the baby is 100% FiO2 on high ventilatory setting, the baby will consistently have low PO2. Comparing to congenital cyanotic heart disease, you will have at least one measurement of PO2 more than 100. The PCO2 will be normal if there is no lung disease, but if there is lung disease, you will have respiratory acidosis. Ductal shunting can be documented by difference between the right radial artery, ABG, and the umbilical artery, as I mentioned before, and a difference of more than 10 to 20 millimeter mercury is suggestive. How you will investigate persistent pulmonary hypertension of the newborn? Usually the chest X-ray will be normal, unless you have pneumonia, unless you have respiratory distress syndrome, or as I mentioned before, secondary to diaphragmatic hernia, you will find it. But if it is idiopathic, usually the chest X-ray will be normal. You might find, as I mentioned, parenchymal disease, air leak. Cardiac schedule typically is normal or slightly enlarged, and pulmonary blood flow may appear normal to reduced. In these cases, we need to do echocardiography. Why you do echocardiography? First, you want to rule out cyanotic congenital heart disease. This is the most important, and also to confirm the diagnosis of persistent pulmonary hypertension of the newborn. You will have a normal structural anatomy. You will have flat or displaced ventricular septum, bulged interventricular septum, right to left shunting at patent ductus arteriosus or patent foramen ovale. And also you need a continuous wave Doppler. And sometimes during your treatment, if you start the treatment for persistent pulmonary hypertension of the newborn, you need echo to monitor your therapy. So you can assess the shunt, is it reducing or no? So the most important thing is the delivery room management. You have to early recognize persistent pulmonary hypertension and correct the factors that prevent decrease in pulmonary venous return. Late preterm or term infant with hypoxic respiratory failure. So if the baby have hypoxia at birth, he will be more liable to have persistent pulmonary hypertension. A pre-duct pulse oximeter at the right upper extremity and saturations are maintained at the range recommended by the NRP, neonatal resuscitation program. So you need to adequately maintain the oxygen saturation for the baby according to his age in the delivery room. And if you need, you will give the optimal oxygen supplementation. What is the supportive management? Of course, you need to maintain the temperature of the baby. If there is any metabolic abnormalities, you have to correct it to avoid persistent pulmonary hypertension like hypoglycemia, hypocalcemia, acidosis, polycythemia. All these factors should be prevented. Parental nutrition, if you need, like if the baby cannot feed for any reason, you have to maintain his appropriate calcium and amino acid supplementation. Previously, we were using paralysis for these patients, persistent pulmonary hypertension, like pancreonium. But currently, should be avoided because it is associated with increased mortality. Due to the underlying shunts, any stimulus can result in a precipitous drop in oxygen saturation. Covering eyes and ears to prevent stimulation. This is also a new modality of treatment for babies for PPHN to avoid the noises. Minimal stimulation. You have to use sedation for the baby, analgesia like morphine, fentanyl, midazolam infusion, according to your situation and according to your institute, what type of sedation you are using. You have to maintain the mean airway pressure. You have to also maintain the blood pressure at normal values for gestational age. If the baby needs volume replacement, you replace to avoid hypovolemia. Inotropes, as I mentioned before, to maintain blood pressure like dopamine, dobutamine, epinephrine. Maintain the urine more than 1 ml per kg per hour. The urine output. Okay. What is the oxygen and the optimal oxygen saturation you need for cases of PPHN? You have to provide adequate oxygenation for the baby. Avoid hypoxia because hypoxia increase pulmonary venous return and will increase, pulmonary venous resistance, and this will cause pulmonary hypertension. Pre-ductal oxygen saturation, 90 to 97%, it is recommended now, which equal to partial pressure oxygen level between 55 and 80 millimeter mercury. Also, you have to maintain post-ductal oxygen saturation more than 70%. Try to avoid oxygen saturation more than 100%. Now I will go to the different modalities of treatment of persistent pulmonary hypertension. We heard about hyperventilation and bicarb infusion previously. It was used previously, but it's no longer used now because it will cause impaired cerebral perfusion and sensorineural hearing loss. With respiratory alkalosis, similar or better outcomes maintaining normal PCO2. So they found that there is, if you maintain normal PCO2, this will avoid, better outcome with PPHN and also less chronic lung disease. Alkali infusion was associated with increased use of ECMO and need for oxygen at the age of 28 days. And most centers avoid pH less than 7. 0.25. So it's not used anymore now. It was previously used, but because of the causes I mentioned, it's no longer used. Ventilation. Ventilation, it's really the main topic we have to talk about. We have two types of ventilation, conventional and high frequency ventilation. And some of the institutes here in Jeddah or in Saudi Arabia, they don't have high frequency ventilation. So neither mode of ventilation was more effective in preventing ECMO, neither conventional or high frequency. But what they found that high frequency ventilation with inhaled nitric oxide is the greatest to improve persistent pulmonary hypertension, especially if associated with respiratory distress. So you have to use gentle ventilation strategies. You have to use optimal PEEP, low PIP, and permissive hypercapnia. And as I mentioned before, that they found that if you have a normal PCO2, this will give better outcome and less chronic lung disease. To evaluate the severity of the lung disease, we have the oxygen index. How to calculate the oxygen index? The MAP, or the mean airway pressure in centimeter water, multiplied by fractional inspired oxygen, multiplied by 100, divided by partial pressure oxygen in millimeter mercury. If the oxygen index is from 10 to 25, we have to consider high frequency ventilation. If it is more than 25, inhaled nitric oxide is considered. And if it is more than 40, definitely ECMO is needed. Unfortunately, most of the institutes here, they don't have nitric oxide or ECMO or even high frequency ventilation. What about surfactant? It's really a promising drug because oxygenous surfactant therapy secondary to lung disease such as RDS, pneumonia, sepsis, or even meconium aspiration syndrome improved oxygenation and reduced the need for it, especially if it is given in the first 6 hours of life. Benefit of surfactant was greatest in mild disease with oxygen index of 15 to 25. Recently, increase in use of surfactant in secondary persistent pulmonary hypertension of the newborn and respiratory failure reduced the need for ECMO. High frequency ventilation, suboptimal lung inflation compromised the efficacy of inhaled nitric oxide in PPHN. How does it work? It augments the response to inhaled nitric oxide in persistent pulmonary hypertension of the newborn associated with meconium aspiration syndrome or diffuse parenchymal lung disease. So it will improve oxygenation. And this is a picture of high frequency of ventilation. Maybe most of the neonatologists are familiar with it. This is the Sensor-Medic. But high frequency ventilation is very, very expensive. It costs around 300 to 400,000 riyals, if not even more. And it needs good technical support, biomedical technicians, skilled operator, central line access, and facility of ABG 24 hourly. And most of the institutes, as I mentioned, they don't have high frequency oscillatory ventilation. What about the last treatment, which is nitric oxide? The most recent treatment. In 1999, inhaled nitric oxide was approved by FDA for use in near-term and term infants with persistent pulmonary hypertension of the newborn. Entering only ventilated alveoli and redirection pulmonary blood by dilating the pulmonary arterioles and reduce the VQ mismatch. So nitric oxide is a selective pulmonary vasodilator. And you can see here, inhaled nitric oxide is a selective pulmonary vasodilator of the pulmonary circulation without any significant systemic vasodilatation, because it combines with hemoglobin to form methemoglobin. So it does not cause hypotension. And this is the most good thing about it. As you can see here, the inhaled nitric oxide will improve the pulmonary circulation by selective pulmonary vasodilatation. What is the cost of inhaled nitric oxide? Usually you need 3 to 4 cylinders of nitric oxide per day. And each cylinder costs around 35 to 40,000 riyals, which is really expensive. Therefore, if you have a baby of PPHN and use high frequency ventilation plus inhaled nitric oxide, the cost will be a very big factor. We'll move now to the cheap treatment, the systemic vasodilators or phosphodiesterase inhibitors. Inhibition of what it will cause this? It will cause inhibition of cyclic guanosine monophosphate, and the name of this vasodilator is sildenafil or milrinone. These two drugs are really promising therapies. Sildenafil, it's a PDE5 inhibitor. It will improve the pulmonary vasculature. It will increase, as I mentioned, the CGMB within the pulmonary vascular smooth muscles and result in relaxation. But it will cause also systemic vasodilatation. So it might cause hypotension. There is available IV and oral forms. Studies have shown that oral sildenafil improves oxygenation and reduces mortality in centers limited by non-availability of inhaled nitric oxide, and the dose range from 1 to 3 milligrams per kg every 6 hours. Intravenous sildenafil is effective, but the risk of hypotension, as I mentioned, is higher. The loading dose is 0.4 milligram over 3 hours, followed by a maintenance dose of 0.07 milligram per kg per hour to reduce the risk. It may reduce also the rebound pulmonary hypertension noted during inhaled nitric oxide on weaning. It's not used in premature babies because of risk of severe retinopathy of prematurity. It was reported before. So I told you all the modalities of treatment. What happened to the case that I presented before? We started oral sildenafil at the dose of 0.5 milligram per kg, then 1 milligram per kg per dose. After 6 to 12 hours, the oxygenation improved and the oxygen index decreased over the next 24 to 48 hours. The oxygen saturation improved pre and post-ductal. The requirement of ventilation setting was decreased, and we stopped the sildenafil after 8 doses. The baby was weaned to CPAP in the next 48 hours, and re-intubation was not needed. There was no hypotension noted at that time during using sildenafil. What about milrinone? It is still not currently licensed for use in treating PPHN, but it is a promising drug. It has the same action as sildenafil. It inhibits PDE3 and relaxes pulmonary arteries, and infants with PPHN refractory to inhaled nitric oxide therapy have responded to IV milrinone in case serious. What is the dose for milrinone? It's a loading dose of 50 mic per kg, followed by a maintenance dose of 0.33 to 1 mic per kg per hour. And this is a dose which is used. Blood pressure should be monitored also because it can cause hypertension. It is maybe the treatment of choice in the presence of liver dysfunction. Or Bosentan. Okay, this is another medication. It is non-specific endothelin 1 receptor blocker in the treatment of PPHN, and mainly in adults. It's not yet used in neonates, but there is some studies show that it is effective in neonates, but still we need more studies. Okay, magnesium sulfate, it is the cheapest drug. And I did one study in 1995, and this is my study actually. I did this study in Maternity Children Hospital, and it was published in Archive Disease of Child, Fetal, Neonatal. We studied 11 newborn babies. We gave a loading dose of 200 milligram per kg of magnesium sulfate over 20 minutes, followed by continuous infusion of 20 to 150 milligram per kg per hour to maintain a magnesium blood concentration between 3.5 and 5.5 millimole per liter. The mean duration of treatment was 75.5 hours. There was no other vasodilators administered before or during the treatment, and the patients were not hyperventilated. What was the result? Really, there was a significant improvement after 34 hours. No systemic hypotension, nor any other adverse effect were found. All infants survived, and the neurodevelopmental assessment were normal at the age of 6 and 12 months of age. So it's a non-aggressive and low-cost treatment of short duration, easy to apply. But this can be used in institutes with not available even sildenafil or high frequency ventilation or even conventional ventilation. So it's really give a good result if you use it together with conventional ventilation. Newer therapy in study, this is still under studies, recombinant human superoxide dismutase, free radical scannerverters, apocynin, and antenatal betamethasone. These all are drugs still under studies, and a lot of researchers are needed. Also, postnatal systemic steroids shown to decrease the duration of hospital length of stay and oxygen dependence in MAP. And only the models were animal models, still not studied on human. Other drugs were still also under studies are prostaglandins, prostacyclins, vasodilator activating adenate cyclase, and increasing cyclic AMP in pulmonary arterial smooth muscle cell. Prostacyclin, inhaled epoprostenol, and other medication also like inhaled PGE1. They are non-RCT evaluating still not evaluating the effect of these vasodilators and their use in neonatal period. So still we need a lot of studies for this new medication. So what is the conclusion? The mortality rate related to persistent pulmonary hypertension has been declining to less than 1%, from 20 to less than 1% in severe PPHN, because it is almost a fatal case if not treated. Inhaled nitric oxide and ECMO are not available in most of the institutes. Even in my institute, I'm working now in IM Hospital, it's not available. Surfactant, conventional ventilation, high frequency ventilation, sildenafil, Mirinon, magnesium sulfate are available in our inventory. So why not to use this medication if you don't have available high frequency or nitric oxide? Wise use of sildenafil seems to be promising. It's cheap and effective, and should be used with parent consent. Newer drugs and researches are ongoing. Hope for cheaper and effective and safe drugs in neonates. And these are the references. I finished my talk. Thank you so much.
Thank you, Dr. Sousan. Our next speaker is Dr. Mariam Rashidi. She's consultant pediatric and nephrologist at East Jeddah Hospital. She shared a lot of talk in national and international symposium. She's going to talk about renal complication of Fabry's disease. تفضلي دكتورة مريم. No sound, دكتورة مريم. دكتورة مريم. There is no sound, دكتورة. Dr. Mariam, we cannot hear anything. There's no sound, Dr. Mariam. Dr. Mariam, log out and come back, please.
Now, is it clear?
Yes, yes, yes.
طيب, alhamdulillah. Sorry for this usual technical problem. Okay, first, my topic today is about Fabry nephropathy, and this is my presentation overview. I will pass quickly through what is the Fabry mode of inheritance diagnosis, and we will concentrate more on the Fabry nephropathy and the management. Fabry is a progressive systemic lysosomal storage disorder due to alpha-galactosidase A deficiency, enzyme deficiency. It is X-linked inheritance pattern, affects both males and females. Globotriazyl ceramide, GL3, and other substrates accumulate in multiple cell types, starting as early as in fetal development. What is the meaning of X-linked dominance? Means that children of affected mother will have 50% chance of inheriting mutation regardless of the gender, while all daughter of affected father will inherit a mutation, and no son of affected father will inherit the mutation, only daughter. The estimated incidence of Fabry disease is 1 in 40,000 men and 1 in 20,000 women. However, accurate estimations are difficult to make, as Fabry disease is likely under-recognized due to non-specific nature and of early symptom, heterogeneous phenotype, and lack of disease awareness. Fabry seen across all ethnic and racial groups. It affects multiple generations in the family, and the average around 5 affected family members per index case. Pathophysiology of the Fabry due to defects in the gene encoding alpha-Gal A lead to deficient or undetectable level of enzyme and progressive lysosomal accumulation of GL3 and other alpha-GALA-A substrate starting in the fetal stage of development. GL3 accumulates in plasma and cell type throughout the body, including renal cell. GL3 accumulates, induce cell injury and tissue response in form of inflammation, hypertrophy, apoptosis, fibrosis, and wide variety of clinical complications. GL3 accumulates, as we said, in various types and cell types of tissue, mainly in vascular endothelial cells, kidney, cardiomyocyte, dorsal root ganglion cells. Here we can see the clinical manifestations seen in Fabry patients throughout childhood till adulthood. The neuropathic pain usually is, or neurological symptom is the most important and usually started first, in addition to GIT, hearing, eye symptom manifestation, psychological, a lot of symptoms, and the life-threatening complication, which may occur at pediatric, but mainly seen in the adulthood stage in the renal and the central nervous system and heart. Disease progress as GL3 accumulates and organ system affected. Early symptom of Fabry progress to life-threatening complication. Survival in Fabry males and females, as seen in the figure, is around 50 and 70 years, respectively. There is estimated 20 years and 15 years reduction in lifespan. How we diagnose Fabry? In males, measuring alpha-GALA enzyme activity in the leukocyte is the gold standard for diagnosis of Fabry disease, but we still perform the DNA analysis to confirm the diagnosis. While in females, usually they have normal to low normal enzyme activity level, and therefore molecular genetic analysis should be used to determine the diagnosis. Even though diagnosis is well understood, study shows that there is diagnostic delay approximately 15 years. And this is important because progressive GL3 accumulation starting in fetal stage leads to triggering of tissue response, and the onset of clinical symptoms start in the childhood stage, irreversible fibrotic damage and major organ complications in adulthood. Therefore, early diagnosis provide an opportunity to intervene before irreversible organ damage has developed. Fabry disease is a fibrotic disease. So progressive accumulation of GL3 in renal cells lead to irreversible fibrosis and end-stage renal failure, which lead to premature death. Progression of Fabry nephropathy started in the infant by appearance of albuminuria, lead to Fabry nephropathy in form of proteinuria, progressive GFR decline, hypertension, and progress to end-stage renal disease in 3rd to 5th decade of life and premature death. So in general, renal failure observed in patients with median age around 42 and progress to end-stage renal failure by approximately 4 years more. GL3 accumulation causes podocyte injury, foot process widening, tissue fibrosis, glomerulosclerosis, which is nearly have same manifestation of diabetic nephropathy with hypertension, proteinuria, and deterioration of renal function. Also, GL3 can accumulate in tubular cells and lead to all manifestation of tubular renal disease. Manifestation includes Fanconi, renal Fanconi, distal renal tubular acidosis, and isocynuria. GL3, we can see here accumulation, GL3 in the glomeruli, the dark blue granule and the scroll like whorls indicate GL3 accumulation, and the red arrow point to endothelial accumulation, while the yellow arrow show mesangial cell accumulation. Green B is the podocyte accumulation. So it accumulates in all type of renal cells. GL3 accumulation in podocyte occur at young age, and the study show that most already had evidence of renal damage at time of diagnosis already, and lead to early podocyte injury, which may precede laboratory abnormality or clinical symptom onset. As we said, widened food process, loss of fenestration, and loss of podocytes. If in so this 11-year-old boy present with normal GFR and just minimal proteinuria, routine creatinine ratio was around 40 milligrams, but the pathological finding showed abundant GL3 accumulation in the electron microscope in podocyte, capillary loop, mesangial, and endothelial cells, which shows that histological manifestation precedes clinical manifestation. Additionally, we can see this widened podocyte food process, loss of integrity of slit diaphragm, and decrease endothelial cell fenestration. This can progress to irreversible fibrotic damage of glomeruli. Additionally, early podocyte injury leads to early albuminuria and or proteinuria, which may develop as early as in first decade of life, and proteinuria level predictive of the rate of decline in GFR. This graph shows positive correlation between widened food process and proteinuria levels. International multi-center study regarding enzyme replacement naive patients show that factors associated with more rapid progression of Fabry nephropathy include lower estimated GFR at baseline, proteinuria, hypertension, and male gender. Usually annual decline or decrease in glomerular filtration rate in Fabry patients is around 12 milli per minute, compared to 4 milli per minute in other patients with renal failure. This means around 3 times quicker in Fabry patients. So as their kidney involved in the Fabry patient, it will progress quickly. How we can diagnose Fabry nephropathy? We look for urine biomarkers. Important biomarker in the urine in form of microalbuminuria or proteinuria appear in infancy, as we said, and podocyturia. Recent case report indicates that appearance of podocyturia precedes proteinuria sometime and consider early as biomarker for kidney damage. This is a vacuolated epithelial cell filled with glycosphingolipid, also can be seen in the urine, and giving appearance of Maltese cross. After this finding and after clinical association, we need to confirm the diagnosis by renal biopsy plus minus proteomic analysis. Treatment of Fabry nephropathy. Initiating of enzyme replacement before development of proteinuria is so important, and controlling proteinuria to less than 0.5 gram per day with help of AC inhibitor and ARBs group to reduce it. Controlling hypertension and hyperlipidemia, renal replacement therapy in patients who already developed in this stage renal failure is the treatment of Fabry nephropathy. Enzyme replacement therapy benefit renal histology in young patients with Fabry disease in form of either reduction in podocyte GL3 inclusion by the mean of 60 months or complete clearance of GL3 observed in glomeruli, endothelial, and mesangial cell in all patients after 5 years. One study showed patients on enzyme replacement and dialysis had progressive cardiomyopathy, while those on enzyme replacement and renal transplant usually had a stable cardiac condition. So the renal transplant is offered the dialysis here. Survival rate after initiating hemodialysis extend up to 17 years, while in the patient on peritoneal dialysis can be extended up to 21 years. Another study on long-term outcome of kidney transplant in Fabry show graft survival are comparable to non-Fabry disease patients. Fabry patient died with functioning kidney from cardiac cause. Kidney transplantation has no effect on the progression of non-renal manifestation. Fabry disease patient survival rate was comparable to non-Fabry disease patients who receive renal transplant. How we can monitor Fabry disease? Optimal care involves careful and periodic assessment of all organ systems with multidisciplinary team. All patients should be monitored for signs of disease burden and progression, including pediatric patients and female. Periodic evaluation should include medical history about pain, headache, GIT symptoms, sweating, and cardiac also, renal, inform albuminuria, proteinuria, glomerular filtration rate, neurological symptom, which is the main presentation in maintaining pain symptom, autonomic testing, neuropsychological testing, brain MRI, and other check eye and hearing. Additional pain management to support the treatment for Fabry disease, we need to take care from the pain management, ACE or ARBS group, to reduce proteinuria, antidepressants, and psychological support, hearing aids, cardiac pacing, anti-arrhythmic medication, genetic counseling, and family screening. Thank you for your attention.
Thank you, Dr. Mariam. Now it's time for questions. I have the first question for Dr. Adnan from Dr. Zahir Rahbini, which is, Dr. Rahbini is a consultant medical genetics at King Faisal Specialist Hospital. He was a speaker in our rare disorder series. He's saying salam according to the talk. Dr. Adnan, can you hear me?
Yes, yes, I hear.
Okay. He's saying according to the talk, there are 13 genes for Moody. However, there are 11 types of Moody. Can you explain more about this? Also, is there any genotype-phenotype correlation of Moody 3, type 3, and when, please? Thank you.
Thank you, Dr. Zuhair, for the question, and thank you for listening to our talk. I'm proud that you are with us, such an expert, really, with us in the meeting. To answer the question, as you know, Moody genes or Moody disorder, when it was described as 5, and then increased to 7, and then 9, and late it was 11. And recently, the potassium ATP channel mutation, ABCC8 and KCNG11, labeled, if it is heterozygous mutation, it will cause Moody. So and if it is homozygous, it will cause neonatal diabetes. So now in the literature, they label them, if it is heterozygous mutation, they label them as Moody 12 and 13. This is the first part of the question. The second part, what is the sharing between Moody 3 and 1, right?
Yes.
Yeah, both shared a lot of features. First, both are progressive diabetes disease. They are not mild disease. They could have diabetes complication later on. Both are actually, they respond to the sulfonylurea. So this is really very interesting finding, that they will respond to sulfonylurea. You will shift them from insulin to sulfonylurea, and they can be treated with that. And both two conditions are actually the commonest with Moody 2. They are the commonest types of Moody in general. So if you want to do, genetic testing, and you want to be lucky to find which condition, do Moody 2 and Moody 1 and Moody 3. Although we suggest to do the Moody panel better, or to do the WIS, whole exome sequencing. And yeah, with that, and but they have two different genes. So I hope I answered the question. And I'm glad to hear also any comment from Dr. Zuhair Rahbini or from you, Dr. Fawzia.
Okay, thank you, Dr. Adnan. I have a question about the genetic testing. Do you do single gene or you do WIS for each patient?
Yeah, as you know, if you do single gene or targeted gene testing, this will be expensive and then it will be negative. And then you go to the next gene and the next gene. So it is recommended now to do either the genetic panel, let's say Moody panel, or let's say, depending on which condition you are looking, neonatal diabetes panel, let's say, or we call it sometimes monogenic panel. But it's maybe, as you know, it's better to go with the WIS, whole exome sequencing. I think our genetists in the hospital say it is cost effective to do the WIS because you put the features and the genetist who read the results will really tell you and when it is really positive or something related to the clinical features.
And it is the same price, right?
I think WIS is maybe cheaper. What do you think? I mean, Dr.
Yes,
Fawzia,
yes.
you are more expert
Yes.
than me.
Yes, yes, it is cheap in some labs. Yes, it is. Okay, regarding the two brothers who have the same gene mutation and different expression, this is one of the characteristics of autosomal dominant, actually. They may have the same gene, but different expression of the disorder. This is my comment. Yes. For, okay. Thank you, Dr. Adnan. The questions for Dr. Mariam. Will be further deposition of in transplanted kidneys for Fabry disease of JL3?
Yes, Dr. Fawzia, please can you repeat the question?
Is there any chance to have deposition? Is there any chance to have deposition in the transplanted kidney of the patient affected with Fabry disease?
Usually no deposition in the transplanted kidney initially, but some study done shows that after a long time, maybe extent after 9 years, there is some colonization from recipient cell start to in the new kidney. So after a long time, maybe from 7 to 9 years can be started, but really no sign of renal or urine involvement after transplant.
Okay, great, thank you. One question for Dr. Sousan. What is the prognosis and effect on neurological outcome for patients with pulmonary hypertension?
Well, the prognosis depends on the underlying disease and depends on how early you diagnose the PPHN and what is your management. So if you diagnose it early and manage it early, I think the prognosis is excellent. If you avoid hypoxia, because it is the most thing which affects the brain. So usually it is a good prognosis if treated and diagnosed early.
Okay, there is another question for Dr. Mariam from Dr. Zuhair Rahbini. Any statistic of Fabry disease in the kingdom and how many patients on enzyme replacement therapy in kingdom for Fabry disease? Dr. Mariam?
And research is limited everywhere, but there is around 5 per 100,000 deaths in Saudi Arabia. This is the last research about the Fabry.
Okay, there is another question for you, Dr. Mariam, from Hawaii Nova. Anyway, is enzyme replacement therapy for Fabry available in Saudi Arabia or not?
Yes, it is available, as you know, Dr. Fawzia. Through our, we refer usually the case to our metabolic and genetic consultant, and the case referred that it is available in Saudi Arabia, alhamdulillah.
Another question, any role of gabapentin in treatment of Fabry neuropathy?
Yes, clear, there is good rule and a lot of research support to start gabapentin for chronic neuropathic pain. The result usually appear after 2-3 weeks, and it is good for neuropathic pain, but not to nephropathy. only neuropathy.
Okay, great. Dr. Adnan, there are comments from Dr. Zuhair. Thank you, Dr. Adnan, for your answer and the kind words that mentioned about me. Okay.
Well deserved,
any-
Dr. Rahbini. Well deserved.
Okay. Any other questions or comments? Okay, at the end, this is the last session of our 5 sessions. I would like to thank all the speakers, Saudi German hospitals, the IT, and the education head, and the education's programs director. And I would like to thank the company that they share with us, Sanofi, Tharwat and Dr. Mamdouh, Biomarine, Ahmed Al-Ibiari and his colleagues, Subi, Basim and Ashwaq, and Primalak. I would like to thank the attendee and thank you very much. We hope to meet in other webinar. Thank you so much.
Thank you. Thank you, Dr.
Shukran. Thank you,
Thank
Dr.
you.
Abedi.
Shukran.
Thank you.
Okay, this is the end of our webinar. Thank you, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh.